and I'll walk you through today's press briefing. Let me first introduce the panel. In the center, we have Dr. Dr. Tedros Adhanom Ghebreyesus. To his side is Dr. Ghebreyesus, the Executive Director for WHO's Health Emergencies Program. Next to him is Dr. Maria Van Kerkhove. She's Interim Director of WHO's Department of Epidemic and Pandemic Management. Then we have Dr. Abdi Mahmoud. He's Director for Health Emergency Alert and Response Operations. On the other side of Dr. Tedros, we first have Dr. Janet Diaz. She's team lead for clinical management and operations. And to her side is Dr. Vasi Murthy. He's the acting lead for R&D Blueprint in the Office of the Chief Scientist. I'm also very happy to let you know that we have online two distinct colleagues. It's first Dr. Anancia. She's WHO representative in the Democratic Republic of the Congo. And we have Dr. Marie-Roseline Belizer. She's the WHO Regional Emergency Director for Africa and head of the Ebola response in Ituri. Welcome to all of you, and to other colleagues we would get in case necessary. Now, quickly to the rules again. We'll have introductory remarks by the Director General first, and then if you want to put a question, please raise your hand with the raise your hand icon, and once we come to you, please unmute yourself. If we have lots of questions, and most likely we'll have so, please stick to one question only. That has been the biggest challenge in the past. So with this, over to Dr. Tedros.
Thank you, Christian. Good afternoon to those in the room, and good morning, good afternoon, and good evening to those online, wherever you are in the world. We begin with the Ebola outbreak in the Democratic Republic of the Congo. It's encouraging to see that since the outbreak was first reported 5 weeks ago, the response has scaled up significantly under the leadership of the government. In the past 5 weeks, the number of treatment beds has increased from less than 10 to over 500 in 19 health centers. With support from WHO and the Africa CDC, laboratory capacity has increased from 30 tests a day at the Central Laboratory in Kinshasa to over 2,000 tests a day in 9 labs across 3 provinces. More communities are becoming aware of the risks of Ebola and asking for the tools and support to protect themselves. And more than 100 people have now recovered. With early detection and supportive care, many can survive this disease. But we could save many more lives with therapeutics, and preparations are now complete for a trial of 2 therapeutics that's expected to start in DRC next week. The trial will evaluate whether 2 antivirals, MBP134 and remdesivir, can help to reduce mortality in patients with Bundibugyo virus disease, alone or in combination. We thank the United States and Gilead Sciences for donating doses of the trial. Together with our partners, we will announce more information next week. WHO and our partners are working closely with the communities to inform and involve them in the trial. We're also working to ensure the communities have access to the therapeutics should they prove safe and efficacious. The trial will be conducted by a consortium of partners, including DRC's National Institute for Biomedical Research, ALIMA, Oxford University, and WHO. Despite the good progress we have made, we still face major challenges, and the outbreak is continuing to outpace the response. There are now 1,094 confirmed cases with 277 deaths. The outbreak is continuing to move fast. Political advocacy and action are essential to create the conditions for increased humanitarian access and a scaled response, because the outbreak is happening in a complex situation. In neighboring Uganda, a new case was reported last Sunday, the first in 2 weeks. This brings the total in Uganda to 20 confirmed cases with 2 confirmed deaths. All cases in Uganda are linked to the outbreak in DRC. Today, France reported that a health worker with the NGO Alima, who returned to the country after caring for an Ebola patient in DRC, tested positive for the virus and is now being monitored and receiving care. This case is a reminder of the risks faced by frontline responders. Almost 80 health workers have been infected, highlighting the risks they face and the importance of strengthening infection prevention and control. WHO advises countries to support the safe deployment of personnel responding to this outbreak. This includes ensuring that organizations deploying staff provide clear information on risks, how to reduce and manage the risks of exposure, and that countries are prepared to facilitate evacuation if needed. Still, the risk to the rest of the world remains low. Under the government's leadership, the coordinated response to the outbreak is starting to take hold, but continued scale-up is needed. Contact tracing is still not at the level needed. Capacity at treatment and isolation centers is insufficient. Safe and dignified burials remain a major challenge. The health system is under pressure. Border closures continue to hinder the response. Multiple security incidents have been reported, and the affected area is in the grip of a decades-long humanitarian crisis, and financial support is still insufficient. Earlier this month, WHO and the Africa CDC announced a joint continental preparedness and response plan that reflects the funding needs of partners with an ask of $518 million. Next week, the first financial reporting on pledges and commitment to the plan are expected to be available, providing a clear understanding of gaps and needs. Now to the outbreak of hantavirus. The total number of cases from the hantavirus outbreak remains 13, including 3 deaths. In all, more than 650 contacts have been identified and followed up by local health authorities in 33 countries and territories. All but 54 contacts have completed their period of quarantine, and the remaining contacts are scheduled to complete their quarantine period by 2nd of July. If no further cases are reported by then, WHO will consider the outbreak to be over. However, WHO will continue working to advance our understanding of this outbreak and hantavirus more generally. Working with government and partners, we're continuing investigations into how the outbreak started and spread among those on board. We're also working with partners who have collected environmental samples on board the ship. In addition, we're coordinating a study among people exposed to the virus involving 21 countries to better understand how the disease develops. We're also working on having a sample of the virus shared with the WHO BioHub in Switzerland. This will be important for developing diagnostics, therapeutics, and vaccines for future outbreaks. I thank all countries that have contributed in different ways to the response to this outbreak, with special thanks to the leadership and solidarity shown by Spain, especially to Prime Minister Pedro Sanchez. I also thank Captain of the MV Hondius, Captain Jan Dobrogowski, his crew, and all passengers for their cooperation in what has been a very difficult situation. Now to the ongoing conflict in Sudan. In the city of El Obeid in North Kordofan, the humanitarian situation continues to worsen. WHO echoes concerns raised by the UN Security Council over the imminent risk of mass atrocities and supports the demand for an immediate halt to assaults. In neighboring West Kordofan, the State Ministry of Health has reported 734 suspected cholera cases and 105 deaths since 15th of May. The outbreak is occurring in the context of health systems disrupted by long-running conflict. WHO and partners are responding to the outbreak by strengthening access to safe water and sanitation, establishing cholera treatment centers, prepositioning rapid diagnostic tests and medicines, and dispatching samples to South Sudan for testing. Finally, countries across Europe and the Northern Hemisphere are experiencing an extreme heat wave. Extreme heat is one of the most serious and rapidly growing threats to health and safety posed by climate change. It claims around 500,000 lives globally each year, yet many of these deaths are preventable. Heat affects everyone, but those at highest risk include older adults, people with chronic conditions, children, pregnant women, workers exposed to extreme heat, and socially disadvantaged populations. Heat waves can also become a major health hazard for people attending mass gatherings and sporting events. During the World Cup, WHO is collaborating with FIFA and host countries on a Beat the Heat initiative to develop action plans, raise awareness, establish early warning systems, improve access to safe drinking water, and implement cooling strategies and smart planning. Fans, workers, and event organizers are all exposed to heat. Protecting them sends a powerful signal, and health must be at the center of global events. Christian, back to you.
Thank you much, Dr. Tedros. And now, before we come to the question and answers, again, reminder, please raise your hand with the raise your hand icon, or do it here with the hand in the room. So we start here in the room. Jeremy, please.
Thank you. The Ebola case in France, what do we know about this case? Is there any danger to the public? And what do the French authorities need to do now to nip this case in the bud and completely get on top of the situation? Thank you.
Thank you very much. And Dr. Abi, please.
Thank you. As DG mentioned, France reported the healthcare workers working with Alima who returned from DRC after caring for Ebola patient. At present, the patient is doing well, experiencing mild symptoms and fever. And we would like to this opportunity to really appreciate the rapid action taken by the French authority in caring and doing all the recommended action. WHO continued to assess the risk to the global population, and France will remain low and will update this. But this case and the action taken in France brings me again to the overall the international surveillance system and how it's been working together through solidarity. Healthcare workers evacuated from Bunia to Germany and high contact being in Austria. We need that global solidarity in support of this. But the dedication of these healthcare workers and all the healthcare workers in France is they are working in an exceptional high-risk environment. Ebola is one of the threats, but the threat of security, armed conflict, abduction threats, crimes, and being in the wrong place at the wrong time is becoming a major challenge. As of today, there have been 7 incidents targeting healthcare workers in Ebola response. This incident demonstrates the real challenge and the heroism that the healthcare workers are doing there. As DG mentioned, there have been 82 healthcare workers infected as they are responding to this, 78 of them in DRC and 4 in Uganda. So WHO really appreciate all the support, and we call on all the NGOs, and my colleague Janet will talk about the heroism Alima and other partners have been doing in the field.
Thanks, Abdeen. Thanks for the question. I think also to acknowledge the tremendous efforts collectively led under the government in DRC, but alongside the partners, including ALIMA, MSF, Samaritan's Purse, IMC, MEDAIR, that have been supporting the clinical operations in the Democratic Republic of Congo, in the epicenter and in the affected health zones. The tremendous work that has gone on to establishing safe treatment centers, which don't get established overnight, take work, take construction, take design, optimizing design, take innovative ideas to ensure that we can deliver safe care and quality care to patients. So together, as the collective effort, that group, as the DG has already said, has built up to over 500 treatment beds in the Democratic Republic of Congo to care for these patients. I think now, as a collective effort, is to deliver quality care. How can we optimize the early diagnosis, which is really important to get patients diagnosed early, get them isolated early to cut the risk of transmission, and to deliver optimized supportive care in line with the recent WHO guidelines that were published just a few days ago. So, and a big acknowledgement to all the health workers, I think those that have been working on the front lines from the very beginning when conditions were challenging, and they continue to be challenging, as Abdi has already described. But at the beginning, where there was still, the treatment centers weren't well established, they were still getting constructed, and really to the bravery and the camaraderie of everyone doing the best they could under those difficult conditions, and the commitment that we have to continue to improve the quality of care in treatment centers across. Thank you.
Thank you very much, both. With this, we go to the platform. And first on the platform, we have Helen Branswell from STAT. Welcome, Helen, and please unmute.
Thank you, Christian, for taking my question, and thank you for doing this press conference. I know that the DG said in his opening remarks that more details of the clinical trial will be coming shortly, but I was hoping we could sort of maybe tease out a few more details today. If Dr. Murthy was willing, could he perhaps tell us, will remdesivir and MBP134 be tested against each other, or are they both being tested independently for efficacy? Are they going to be tested as prophylactic treatments or just as therapies? And how large do you have to think those? Do you think those studies will have to be to get an answer? Thank you.
Thank you very much, and we'll go to Dr. Vazimoti. I didn't hear you too well, Helen, but Dr. Moti, you understood. Good. All right, we're good.
Thank you for the question, Helen. So to start by saying that it's really important to emphasize that all of the research work is integrated into the response. And so I want to acknowledge the fantastic work of everyone who has been scaling up safe care, led by my colleague, Dr. Diaz. And that work is an essential prerequisite to starting the treatment trial. To your question, so MBP134 and remdesivir are, as you know, the two agents in the treatment trial. And as DG said, we're hoping that this trial will start next week. All of the preparations are essentially complete for that, so we're just going through the last steps. The protocol is actually on the website, so we try to maintain maximum transparency. We can share the link for you, and you can see in the protocol that those therapies, so they are being tested, to your question, as therapies for confirmed cases. So we will have from that trial the answer as to whether remdesivir is safe and effective as a treatment for Bundibugyo disease, also whether MBP134 is safe and effective, but we will also, because of the innovative design of this trial, have information as to whether the two in combination are effective and potentially more effective. In terms of the size of the trial, that was your other question. Fortunately, the case fatality is somewhat lower for Bundibugyo than for Ebola. And so that does have implications for the size of the trial. It means that we are looking at around 1,000 that would need to be enrolled in the trial before we expect that there will be an answer about the safety and efficacy of any of these options. And in terms of how long that will take, we will be incrementally expanding the clinical trial across multiple facilities. Partners including ELIMA, MSF, Samaritan's Purse, and IMC are all working with us and are intending to bring their facilities into this trial over time. Thank you.
Thank you very much, Dr. Murthy. We come back to the room, and that's for Catherine Fiancon, Franz Rankot, and others.
Thank you, Christian. Thank you for this briefing. I have a question on Ebola in DR Congo, and particularly the situation in Goma, in the region close of the border of Rwanda. Could we know a little bit more about the cases there and the work that has been done, and also the needs in that region, which is difficult to reach? Thank you so much.
Yeah, thank you. I think since I saw Dr. Ancia and Dr. Marie-Roseline Belizia sitting next to each other, we'll hand over to them and move forward there. Over to you.
Yes, thank you. There is no more case of Ebola in Goma. There has been actually, for the time being, one probable death and one case. All the contact, and there were 70 high-risk contacts that were isolated, and another couple of 100 that were actually followed. All those contacts have now been released because they have been followed for 21 days, and none of them has demonstrated symptoms. So what's happening right now in Goma is actually intense preparedness. WHO and partners are particularly strengthening community surveillance. They are training epidemiologists, and they go in all the area outside Goma. We've got a team that is actually right now in Rutshuru, and they are training field epidemiologists to do community-based surveillance. So we are really trying to strengthen the active research of potential case in all communities in Goma. Laboratory diagnostic have been also decentralized, so there is an excellent diagnostic in Goma, one of the best of the country, maybe after Kinshasa. And a part of a mobile lab has now been decentralized in Kenya as well, to be able to eventually, if cases would come from the north, they could be very early diagnosed, maybe before they arrive in area which is more populated. Point of entry has been as well established, and the treatment centers has been finalized. So for the time being, there is 2 treatment centers in Goma. One that is in the provincial hospital and has a capacity of 20 beds, and the other one, which is a treatment center that is supported by Doctors Without Borders, has 21 beds that can welcome potential case, and can expand actually to 40 beds, and another capacity to also welcome 10 confirmed cases. So preparedness is ongoing, surveillance is strengthening, community mobilization is as well ongoing, and actually for the time being, supplies can be received through Rwanda and the border, then crossing the border and entering Goma from Rwanda.
Thank you very much. Seeing if anybody wants to add something. Nope, then we go to the next question. That's Priti Patnaik from Geneva Health House. Priti, please go ahead. Priti? If we can't
Hear me?
now we're good, yes.
Okay. Sorry about that. Thank you for taking my question. I had 2 quick questions. One is, whether WHO can comment on, the modes of information sharing during this current Ebola emergency. We understand that the information, pathogen information was initially, has been released on a restricted use. Basically just trying to understand the implications for the PABS negotiations. What do we learn from this outbreak? And the second one is, we increasingly hear from other briefings as well that there isn't a lot of coordination on the ground between CDC and WHO. And maybe if you can throw some light on the challenges on the ground in terms of coordination, also in light of the withdrawal of the US. Thank you so much.
All right, we have two sequences here, so we start first with Dr. Maria Van Werkhoff and Dr. Abdirah Mahmoud.
Thanks very much. I think I'll start it, but I do think others should come in specifically related to the event here. I think your first question was related to modes of information sharing, but also pathogen sharing or biological material sharing as well, and its implication for PABs. So I think, number one, the information sharing that's happening, we have the international health regulations. Countries are sharing regular information about alerts, and Abdi might want to come in on how many alerts that we are looking at, not just in the DRC and Uganda and neighboring countries, but globally. He addressed this when he addressed the first question as well. Information is being shared through IHR, about the cases that are being reported and a lot of detail that's there. So we're very grateful for all of the countries that are regularly and routinely share this information for Ebola, but for all other infectious diseases according to the international health regulations. There have been materials that are being shared, sequences are being made available, and they're being provided to databases that exist. That we are working to have samples shared with the WHO BioHub, and there are regular mechanisms to utilize this. I do think it is important as the member states continue to discuss PABs, the pathogen access and benefit sharing system, that they are negotiating in good faith and wanting to get this done, and I am confident that they will get this done as soon as possible. It's a great example of how the system currently exists and why the pandemic agreement is so important and why it's so critical to actually finalize the annex of the PABs agreement. So in the discussions that they're having some informals right now. They are in some discussions in some channels are having discussions about hantavirus in particular, and the current Ebola outbreak are being utilized in terms of how things are shared. So it is important that that contract is finalized, the annex is finalized, so that we do have that commitment by all member states to share, regularly share information. And pathogens are shared as well for the development of diagnostics, therapeutics, and vaccines. But my last point to highlight is that one of the global goods coming from sharing of information are these risk assessments that are regularly being done. And this is being done by WHO regularly, and we're reporting on this regularly. Again, relates to what is the global risk in terms of the Ebola outbreak, which is low, what is happening in the DRC, what is happening in neighboring countries, and we will regularly conduct those risk assessments and share that information through all of our member states to the public to make sure that they know what actions that they need to take at the government level.
And Dr. Mahmoud?
Thanks. And the second part of the question was about our collaboration with USCDC. Yes, we work with USCDC both at the global level. On a weekly basis, we have a call with them to discuss the technical issue. And on the field, my colleague should have answered, our WHO representative there and is in a close contact almost every day with the USCDC country director. And we are in the process of ensuring, because they are not able to go to the field, to link them so that they can participate in the coordination. So at the technical level, both in the field and at the global level, there's an excellent collaborations, and hopefully this will be strengthened. I think this outbreak has shown that we, WHO and USCDC and the US government, how important is it, how critical it is in collaborating in the field, sharing information, everything that's required to respond. Is the core pillar of global health security.
Thank you very much, both. With this, we go back to the room, and I believe, John, you had your hand up.
Yes, good afternoon. My question is to Dr. Tedros. Dr. Tedros, there's some very alarming new estimates that official development assistance for this year will be declining again by double digits, with health ODA adversely affected. What does this mean for your current countermeasures in the field on the current Ebola outbreak, where you're looking for funds? And secondly, will it force you to revisit your budget projections for the organization? Thank you.
big shift of topic. Can we take that? Thank you.
First of all, I don't have that information you just shared, whether ODA will decline or not. But I hope that will not be the case, because, as you know, in 2025 alone, the decline in ODA was 40%. So that's, I think, serious decline. And many of the development and humanitarian, institutions have been affected. But as I said it in the past, I want to remind our leaders that, of course, they have other concerns, but they can strike a balance. I see increased investment in military expenditure. It's close to 3 trillion a year now. What development and humanitarian actors are asking is a fraction of that. So if our leaders spend that much money to kill each other, maybe, allocating money to fight viruses or other humanitarian problems, I think should be considered at the right cause, because it protects us all. So that's what I would like to say. I don't want to go into the details of this much reduction or not, but if they could strike a balance, and of course take care of their other priorities, but without neglecting the common problems humanity is facing. Then when it comes to WHO, as far as our forecast is concerned, for 26-27, we have already 90% of the funding we need, and I don't see any problem in the near future. We had a town hall a few days ago. Of course, our colleagues were concerned about second wave of separations, but I assured them that that will not happen, because from our projections, we don't see that. We have already taken measures with regard to our budget and with regard to our structure, and we have already stabilized and moving on. So I don't expect surprises. I think WHO will continue to stabilize. And the confidence comes also from the finance reform we started 8-9 years ago, broadening the revenue base of the organization. That helps to prevent shocks in the future, but at the same time ensures our independence as well. So I would like to share with you that there is stability and we're moving on, and I don't expect what you said, and that's what I gave assurances to my colleagues as well. Thank you.
Thank you very much, Dr. Tedros. Now we go back onto the platform, and next here is Rami Inocencio from the CBS. Rami, please go ahead. Rami, you would need to unmute yourself, please.
Can you hear me now?
Now you're good, yes.
Okay, great. Thank you. Sorry about that. Yes, thank you so much, everyone. I've just come back from Uganda, and I've been reporting on the Uganda DRC border for the past week or so. And looking inside the DRC, we've been talking about Goma. I appreciate one of our fellow peers asked about Goma, but where else do we need to be looking for contact tracing? It's a question of we don't know what we don't know. Of course, everything is centered in Ituri, but as these health zones expand, people continue to migrate. Where else would you like to see resources on behalf of WHO and other aid agencies as we continue to surge more people and more resources in?
Thank you, Rami. I think let's maybe first go to Anansia, no? Or let's start with Dr. Let me first go to Dr. Anansia, and then we'll come back to Dr. Mahmoud. Dr. An.
Yes, thank you. So first of all, let me maybe explain one of the challenges that we've got with contact tracing, and it's really specific to the demographic of this outbreak, and particularly the epicenter of this outbreak. As you know, this outbreak is the epicenter of this outbreak is in Mongwalu, which is a mining area, and actually this place is mostly frequented by young men. If you look at the demographic and really the distribution of affected population, you would see that it's mostly young men from 20 to 50 years old. And so those are young men who are coming from various parts of Chopo, Bawele, Howele, North Kivu, and they come to try their chance in the gold mine in Mongwalu. They come alone, and they sometimes don't have a lot of contact with the population. So when they got sick, sometimes people don't know, and they try to return. Actually, they don't always want to be seeking care in a community where they don't really have attached, and they try to go back home, and they start walking, and they actually in the highly symptomatic and highly transmissible phase of their disease, they go to new health zone, and they seek care in new health zone, and it's how we've got so many health zones that are affected. They try also, a big part of the population as well, try to go to the north of North Kivu, to Beni Butembo, and it is also why we have a high case fatality rate over there, because they arrive too late, and when they arrive in the Ebola treatment center that we've got there, it is sometimes too late to be able to get them. So we need to do contact tracing in all those areas that they have crossed. And because they're not known by the population, it is extremely complicated because, for example, some of them die in those communities, nobody knows them. And so it's very, very complicated to be able to identify and then trace their contact. And it's one of the challenges that we've got. So we still need to go in all those health zone of Ituri. But we are also now starting to strengthen preparedness in Chopo provinces, in Howele, in Bawele, as well as in Kinshasa, because we think that those areas will be those areas where we've got the highest risk now to find also affected or infected people. So this is where we are now strengthening preparedness. We've got now a laboratory in Chopo, in Kisangani, and we are establishing one in Howele as well that will be able to do diagnostic. We are strengthening surveillance there, and we will also in the following weeks ensure that there are Ebola treatment centers that are set up in those areas.
Maybe I can add something. So other place also where we are strengthening contact tracing is an IDP camps, in internal displaced population camps. As you know, we have 69 official displaced population camps in Bunia, in Ituri, and 48 that are unofficials, and all of them are at risk. And so far, we already registered some Ebola cases in some displaced population camps. For example, one in Kigonze, where we have 25,000 population in that camp, and we already have confirmed cases of Ebola. So those camps are also very, I can say, important for us, and we are strengthening capacity there, and we are considering how we can increase contact tracing on those camps. As you know, it's a very a lot of promiscuity in those places, but also a lot of needs, of humanitarian needs. I think this is also another aspect that we shouldn't forget about this outbreak. It's happening in a very, I can say, humanitarian situation. We have been in those camps, and we really witness the needs. They don't have latrines, they don't have access to water, they don't have, where to sleep, where and what to eat. That has been more than 8 months to 10 months that they never receive any humanitarian support. And this population are really living in very, I can say, difficult situation. Other place where we are also looking at and put a contact tracing and preparedness in place are those closed area, like in the corrective houses that were in prisons. We are also set up there a treatment center in case there is an a suspect case is quickly isolated, because we have so far 2,000 prisoners in the prison in Bunia. So we are really putting in place a system where we don't leave no one behind, actually. Over.
Thank you much. Do we want to add from here? Dr. Mahmoud, please.
No, thanks. I think they have covered very well the risk categorization within DRC and how important it is to increase our concept of operation, our WHO under the leadership of the government to support them. In addition to DRC, we have another layer of countries. One is DRC and Uganda, where we have evidence of active outbreak going on. And then the second layer of priority countries are the one neighboring South Sudan, Rwanda, and Burundi, where there's a lot of intense operational readiness actions going on in terms of risk monitoring, establishing laboratory, historical, cultural, commercial link between these countries. And then there's another layer of countries where we call them priority two. That's the Central African Republic, Republic of Congo, Tanzania, Zambia, Angola, Kenya, Somalia, Ethiopia, where there's a historical travel and land border means. So each of these priority as part of what DG mentioned as part of the continental SPRP that we launched with Africa CDC, and it requires investment support to those member states and the partners who are providing that. So I just wanted to add that 2 points.
Thank you all very much. And next question goes back to the platform again. Benjot Kaur from The Wire. Benjot, please go ahead and unmute.
Hi, Christian. Thanks for taking my questions. I wonder if one of the panelists can talk a bit more about contact tracing, because as we hear in the briefings, which by the Africa CDC director, he has been constantly talking about less than 20% contact tracing. So what are the major problems because of which we are seeing such low numbers of contacts being traced? And where does it take us? How does it overall impact the outbreak and its trajectory?
Thank you very much, Banjot. Do you want to go back to the countries first? Dr. Ann or Dr. Marie-Christine?
Okay, thank you so much. So the latest number that we have of contact tracing, so far we have 8,000, more than 8,270 contact that has been listed, with a rate of follow-up of 72%. Yes, when we disaggregate on this data, we can see there is a difference between the three provinces, between the Ituri provinces and the North Kivu provinces. So this data also, we are going deeper. So now, so far, we have a decentralized system in health zone, and within the health zone, we are going to health areas. That is the smallest unity division, administrative division of the health system. So in this, so we are now training the community healthcare workers that are responsible to trace those contact that has been identified in their locality. So we are also using this strategy not only at the health area, but also at the zonal area where we need those data to be scanned up. Other measure that has been putting in place now is the digitalization of the contact tracing. So the system can become when we have a contact that is a trace and become a suspect, so we can know what is the follow-up of this contact into the system that can help us establish the transmission chain in order to know what are the new transmission that has been produced in this outbreak. Yet, we still know to get at the target of 95%. And so far, we are also working with I can say, local community in order to identify the high-risk contact that when they are displaced. And we are also working with a World Food Program in order to provide food for those contacts that they can stay at home. Because as my colleague had mentioned, this is a very mobile population, and they are very mobile because there's a daily subsistence that they have. So they have to move in order to find what they need to eat every day and what they need also to support their family. So if we provide them with what they need, so at least they can stay in place and not follow the contact during the 21 days. So far, this is all the strategy that we are putting in place. You want to add something?
Thank you very much. And just to correct my colleague's name, this was Dr. Marie-Roseline Bélissière. She's WHO Regional Emergency Director for Africa. Next question goes to Jonathan Lambert from NPR. Jonathan, please go ahead.
Hi, thanks for taking my question. There have been some reports of shortages of reagents for testing over the past couple of weeks at some labs. Can WHO comment on whether this has been an issue that's ongoing and has limited testing capacity at some labs? And then more generally, are there plans to continue scaling up testing capacity by adding more labs or adding more testing machines within certain labs? Thank you.
Thank you very much, Jonathan. I think we have two colleagues here who could come into this, but let's start with Dr. van Kerkhoff.
Yeah, thanks. So thanks very much for raising the question, and certainly we want to be scaling up laboratory capacities across the country, but also in the at-risk countries, as Abdi has pointed out. So at the present time, and DG said in his speech, the country in DRC has the capacity to test 2,000 tests per day, and that's up from 30 in the beginning. We have 9 testing sites across the country right now. We have reference laboratories with INRB in Kinshasa, INRB in Goma, and I really want to say a special thank you to the hard work of INRB and the collaboration and the expansion of the work that they have done for testing capacity across the country. A big priority of the response is to scale up decentralization of the testing. And why that is so important is because we want the tests closer to the patients themselves, closer to the individuals who need those results. Testing for testing's sake is useless, but testing for action is what is critically important for surveillance, to really understand who is a confirmed case, who is not, also to ensure that people get the right clinical care and show up at the ETUs to provide the care that Janet has described. Also testing to ensure that the safe and dignified burials are conducted for those who are infected with the virus, or the bodies can be released to the families of people who are not infected. It is absolutely critical. So we are working with colleagues in the DRC around coordination of human resources, of the logistics for the procurement, for the equipment and the testing supplies, including the reagents that you have mentioned. Certainly in the beginning, there's a challenge of having reagents, having the right materials in the right locations, but that is something that is scaling up and will continue to be scaled up. There are 4 testing sites in Uganda. We are also supporting logistics and procurement to support testing in Uganda as well, and looking more at the preparedness in the region and at the at-risk countries, looking at procurement needs, looking at capacity assessments in the countries, training for the right types of testing to be done, quality assurance of the testing in those laboratories that are doing the testing, and of course sharing of different materials and reagents that would be required. So WHO's role in this is largely around partner coordination, looking at for the diagnostic response to make sure that the supply is adequate, that the right tests that are validated, that are accurate, are being used in the right locations, and as I mentioned, are being used as close to the patient, as close to the person as possible. We also have an EUL process that has been activated for tests. So please, we can put the link in the chat for those who are working in that area. We're working with our EPI and our modeling colleagues to look at forecasting of need. We're doing something similar for beds and needs for beds. And of course, we're doing this all under the coordination of the Continental IMST, and with partners. We're working with Africa CDC, with FIND, and with many, many others in this space to expand the range of the recommended tests that actually can be used in this outbreak.
Thank you, Dr. van Kerkhoff and Dr. Wasi-Multi.
If I could add from the research side, just to complement almost everything that Maria talked about, and this is why we always talk about the research being integrated into the response, could also apply to setting up the clinical trials. So a critical aspect of the setup for the clinical trials is the laboratory resources, so the human resources, some specific equipment, reagents, quality assurance, training is all needed also for initiating the treatment trial and later the prophylaxis trial and the vaccine trial. So we are also supporting any specific additional elements on the laboratory side that are needed for clinical trials, including procurement and logistics, and that's going well. Thank you.
Thank you both very much. Just a heads up, we have 3 more questions now pending, and we'll close the book after that. We have Janice Koo from Bloomberg, Mohammed Aslan from Anadolu, and then a follow-up from Helen Branswell. So we start with Janice Koo from Bloomberg. Janice, please go ahead.
Hi, I just wanted to circle back to the French patient. I was wondering if you could give any more detail about whether he was diagnosed only after he returned to France, and if so, how long that delay was, whether he flew commercial, any sense of how many contact persons there are to trace related to that specific case.
Thank you, Janice. I think we want to go to Dr. Abdi for these details on infection and time span and everything.
Thanks. As I mentioned earlier, those details have been compiled, and we are waiting to hear from France. As soon as we have, we will update them in our disease outbreak news.
Thank you very much. And yes, we're standing by for that one. Then we come to Mohammed Aslan from...
Can I?
Oh, yeah, of course, Dr. Tedros, sorry.
Yeah, so on the French case, I think maybe having a kind of perspective will be very important because whenever a case happens in Europe or other parts of the world outside Africa, I see overreaction. But I don't think overreaction is important, needed. No need for panic, because in the past 50 years, the number of cases that were detected outside Africa are less than 30. Of course, tens of thousands of cases in Africa, but less than 30 in the rest of the world in 50 years. So the risk to the rest of the world is low. So no need to really, in our reporting as well, I'm talking to the media as well, I think we need to tell the whole story. And the risk is low. I repeat, the risk is low. Imagine in 50 years, if it's 30 cases, less than 30 cases actually, it's not even 30, I think 26 or 27, then I don't see, a change here. I don't expect. So in our reporting, I think we need to be very careful. And since 1976, that's when Ebola was detected first, in the first outbreak. And since then, less than 30 means the risk is low. Whether it's France or other countries in Europe, they shouldn't overreact. That's what I would like to advise. Thank you.
Thank you very much, Dr. Tedros, for that perspective. Mohammed Aslan from Anadolu, please.
Thank you so much, Christian. As Mr. Tedros said, many countries around Europe are experiencing extreme heat waves. My question is, do you have any data that shows how many people died because of extreme heat this year in Europe or all around the world? Thank you.
Thank you very much. So this is about the ongoing heat wave. I think we have online Dr. Ninglan Wang. She's unit head for border mass gathering and health protection measures, and that includes heat waves. Let's see with her first, and then we'll come back to the room here. Ninglan, anything to add here? Statistics on heat wave victims?
Thank you very much for this question. I do not right now have that in hand, the statistics or numbers, but we do have the Beat the Heat initiative as already mentioned by the DG in his opening speech in terms of, how we support the country, especially for those countries, host countries of sports games and mass gathering events, and to support them in terms of protect the health and safety of the spectators and the communities by addressing those associated the risks of heat and other environmental factors such as air pollution and the UV exposure. So we do support the countries by providing the operational guidance, evidence-based the risk communication messages and risk mitigation measures for those people and countries and communities in the involved in those events. So one of the example I can say is that we support countries by translating all this public health advice into the actionable service for the mass gathering events and their participants. For instance, the travel advisories that we supported the FIFA World Cup. So with this risk mitigation measures and message, we emphasize prevention of the heat-related illness, adequate hydration, effective risk communication messages, and the preparedness in crowded settings. So I will stop here. Sorry, we will come back with the statistical figures. Thank you.
Thank you very much, Ningran Wang. And we'll go to Dr. Teresa Zakaria. She's unit head for risk reduction and humanitarian operations.
Thank you very much for the question. I think what we are currently seeing and experiencing in Europe is very concerning. What's very important to underscore, however, is that we are not seeing the end yet of this extreme heat. With El Nino conditions actually now predicted as very, very likely starting actually the second half of this year, we know that the projection for extreme heat in the next 6 months is quite dire, with the vast majority of territories on Earth actually very likely to experience temperatures way higher than normal, in some areas up to 80% higher than average temperature for the same months of the year. And so this is extremely concerning because, as DG mentioned, heat can have profound health impacts on individuals, on everyone, but especially those who have medical conditions, who are at more vulnerable age range, the very young and the older people, and especially those who are also living in poor shelters, those who are living in displacement camps, and very, very low resource settings. And so heat is going to impact almost the entire population of the world in the next 6 months. And it's very important that we actually act early. From the health perspective, we are concerned, of course, about the direct impact of heat, but also other extreme weather events that El Nino will cause in the next 6 months. We are also concerned, of course, about the basic health conditions, basic health status of the populations who will be impacted, those who had a very poor access to health services to begin with, and therefore then also the capacity of health systems to respond to increased health needs from people across the world. And obviously, this concern is even more pronounced in areas, in territories where health systems are already struggling, conflict zones, areas where energy crisis is severely impacting access to healthcare. But there is an important, a critical window to actually act now and make sure that that risk that we have already identified for the specific populations that we have identified the risk for, that measures are taken now, that medicines are secured now, that food productivity is increased now, that resources from governments, private sectors, and everyone to make sure that there is that safety net that can be secured in advance of the progression of El Nino is actually done now, because in the coming months, these may actually be very much too late. But we will be continuing to monitor these health impacts in Europe and across the world, and we'll keep, of course, everyone informed. Thank you very much.
Thank you very much, Dr. Zakaria and Dr. Wang. Now, we started with Helen Brenswell. Helen, we're coming back to you for the final question or follow-up. Please go ahead.
Thank you very much, Christian. Can you hear me okay this time?
Yes, good.
Great. I wanted to say that I've been watching the numbers of case contacts that DRC has identified and is monitoring, and I know the percentage has gone up, but the denominator is still very low. It's, about 7 or 8 cases, contacts per case, which seems very low in an outbreak this large. Dr. Anancia's comments about the challenges at the epicenter were very informative, and I appreciated hearing that. But can somebody give us an idea of what is realistic in this setting in terms of how many contacts per case should be identifiable and followed up? Thank you.
Thank you very much. We want to look Dr. Mahamud first. Let's look at Dr. Anancia first, as she was quoted, so to say, by the question. Anne, are you there?
Yes, I will start and Anna can add. First of all, the first thing to know is that the contacts are not cumulative. So at some point, we have also to release the contact because the follow-up is on 21 days. After 21 days, we have a part of the cohort that has been to release because they finalized their follow-up. And so far, we have 8,278 contacts that are under follow-up. And in the last 24 hours, we have seen 6,023 contacts that has been seen in the last 24 hours, which is a rate of 72.8. Yet, it's still not yet at the target, and we can explain so many factors that make this to reach this target very difficult. But we are working on it, and we are putting all the measures that are necessary in order to reach there. So far, based on previous experience that we have in other outbreaks, and we have established some what we call a contact mapping. The contact mapping take into consideration all the people that a confirmed case has met during the disease, but also we can go back in the, retrospectively to look at where this contact has also been possibly been in contact with other person before getting sick. And that's what we do. We do that mapping starting at the date of onset of that contact. And we look at where are the places this person has been doing all the time before entering what we call an health infrastructure or die. And even during the disease, we also look at how many people can even be at the funeral. So in average, when we look at all those aspects around a case, we found that a case should have at least 120 to 200 contacts based on the experience that we have in this. And we are looking at this data in order to make sure that we really take everything, we don't lose any possible contact. And now when we have that number, we classify them into 3 categories of contact. We have the high-risk contact. Those high-risk contacts are those who have been really touching the excretion of this confirmed case, sleeping with that confirmed case, taking care of that confirmed case, really family members who have, or healthcare workers who has been in very close contact with those. So we classify them as high risk. We have a second category that could be, for example, those who have been in a place where this person has been during the disease, during the time presenting symptom, but they didn't have really touching, relationship. And we also have a third category of contact. It's with, for example, someone who has been, I can say, in a place, but the distance was respected, the 2 meters was respected, but that person was present at the same moment in that area within those contacts. And we classify them with those 3 categories, and then the follow-up must start when the starting of the onset of the date of onset also reported in the system. If it is, for example, a dead body, a community death, the follow-up of the contact not only started when the person start dead, but we also count when the person is buried, doing the safe and dignified burial. So now we have also to classify. If it was a death in a health infrastructure, or if a death in the community. If it is a death in the community, it's more risky for us. This is where we have to find those 200 cases around this case, at least. In some cases, we have found, for example, dead confirmed cases with 500 cases, and it can vary. As Anne explained, a lot of our cases that we have, they don't have family. They came here to work in the place to work and they died. They have not been really in contact. They didn't have a lot of family that has been taking care of them. So this is more or less how we organize the contact tracing and the classification of contact around a confirmed case. Do you want to add something?
Maybe what I can add is actually, as Marie-Rosine said, there was a study that was done very recently, I think 2 weeks ago, as well as looking at the number of contacts and the type of contact that were mentioned. And we realized actually that we had to strengthen our investigation because we could see actually that the number of contacts per confirmed case was too low. And also we could see that most of the contacts were actually regarding the people that were already in the health infrastructure. So we knew that we were missing some information. So we actually now starting to strengthen the investigation that we do for each and every confirmed case so that we can make sure that our investigation are complete, are comprehensive, and then we can really try to extract all the information to make sure that we've got as many contacts as we can, because we knew that probably there was a problem with the investigation that was too superficial in the previous week.
Thank you so much, Dr. Marie-Rosine and Dr. Ann, and Dr. Mahmoud Naum, please.
Thanks. I think my colleagues have gone into the details explaining. Just wanted to put in the context of where the situation is. When you compare in South Kivu with Miti-Murhasa, we haven't had cases, and the contact tracing is excellent. All the contacts, and you can textbook in terms of where they are, the tracing and the quality of the contact. When moved to Uganda, out of the 20 cases, you have 824, an average of 40 contacts. That's what we expect. But in the places where there's an intense transmission going on, whether Bunia, Mongwalu, Nyakunde, Rwambara, it becomes the quality and the quantity. And as our WR ANSI said, we're improving that. And it's a work in progress. And the biggest advantage and indicator we'll be looking is proportion of those contacts who become confirmed cases. So we have a quantity issue and quality issue in these 5 health zones with the active intense transmission. While the rest of the country, be it in Aru, Miti-Murhasa, Beni, where the number is small, the quality is high. So, I mean, adding the 1,000 divided out of the contact will not give you a clear picture. We need to look at the health zone levels to have the totality and the quality of the contact tracing happening in the country.
Thank you also very much. This brings us to the end of the questions, but let me hand over to Dr. Chikwe Ihekweazu for a bit of a summary here.
Thanks, Christian, and thanks, colleagues, for all the questions. Having spent 3 weeks in the field and just coming back from Bunia, I saw firsthand an evolving response to a significant Ebola outbreak. You know, the challenges of an Ebola outbreak are well documented. We understand each of them already, and we're responding to each of those. In addition to that, we're facing a complex set of circumstances, a humanitarian context that is very challenging, a security context in part of parts of the 3 provinces affected, food insecurity, IDP camps in parts of it. On the other hand, there's a thriving community, thriving cities involved, a mining town in Mongwalu and others that have been described. Now, all of these stories are true, but none of this is a single story that describes the 3 provinces affected. They're very diverse, and therefore we have to also look at them with the diversity of the stories that we're hearing from them. In addition, we're facing an outbreak a virus that we're just, to be honest, beginning to understand. This is just the 3rd emergence of this. So with the time spent there, understanding, working with the teams in the field, working from the levels of the minister, the political levels, the government, the institutions, INSP, INRB, the Provincial Department of Health. You know, what I saw that was very encouraging was the determination of the government of the DRC itself, its institution, its scientists, its public health practitioners. They were not waiting for us. They were leading the response, and we were supporting. And they woke up every morning and drove this response forward, and we supported them in so many other aspects, and which has led to an emerging response. And if you look at all the pillars of the response, there are still significant gaps, and we've referred to some of them today. But if you look at where we were 3 weeks ago, 2 cases, bringing them into care. 4 weeks ago, when we got to Bunia, there was only 1 lab that was able to make this diagnosis. Right now, there are 9 labs across the 3 provinces able to make this diagnosis. This is a little miracle for it to happen, because it's not just setting out a few equipment and reagents. It's providing power, providing security, logistics, transport, sample transportation, result notification. All of these are necessary to set up in order to get a lab to work. So the response is scaling, infection prevention and control, supplying all the health facilities, not only those with cases, but all the healthcare facilities in the area with the IPC post PPE that they require to respond. Building up care and treatment. My colleague Janet just referred to over 500 beds available for the response today. And I know that on Saturday, a big new center for over 100 beds will be opening in Beni, in North Kivu, increasing again the bed capacity by another 100 beds. So each of these aspects are small miracles happening every day. Having said all of this, the challenge with Ebola is that even 99.9% is not good enough. We have to keep pushing to the very end till we get all new cases emerging from known contact lists, which is the most important criteria for success of an Ebola response, when every new case we find is among the list of contacts that we're following. So this will be a marathon. That you've improved from 30 to 70% is not good enough. We have to keep pushing, and that's what we're determined to do, and that's where we need the support from everyone, all the countries around the world, to keep enabling, supporting the response we're building up, supporting the government of the DRC in this response. So I'll end here by saying we're in a much better place than we were 4 weeks ago. We're nowhere where we need to be, and the challenge and opportunity of an Ebola response is that there's no such thing as a 99% success rate. We've got to get to 0, and we will get to 0, but it will require us continuing on this race to the very end. Thanks, Christian.
Thank you so much, Dr. Chikwe. Now, before I give back to Dr. Tedros for closing, just a reminder, the opening remarks and the recordings will be shared soon after this briefing. For anything else, please contact media inquiries at who.int. Back to Dr. Tedros.
Yeah, thank you. Thank you, Christian. I think the contact tracing, there is a lot of interest in the contact tracing. Of course, there is improvement, but it's not enough, as Chikwe said and other colleagues as well. And I think understanding the environment in which the responders are operating is very important. And as Chikwe said, since I was on the ground, I would like to share some of the things actually we have heard from the people. For instance, one thing that is affecting this response, especially in terms of contact tracing, is the reduced incentive. So the issue is when we had the Ebola outbreak 2018-2020 in Beni, during ring vaccination, we used to offer vaccines to those contacts, and that was the incentive that was attracting. But now, okay, you ask someone and there's a contact, there's nothing to offer. Actually, if there is even quarantine involved here, most of them are daily laborers. There is the economic fear, so they don't want to come forward because for what? One, they don't get vaccines, or second, if there is quarantine applied, isolation applied, then they can't have even their daily bread. So you see the dilemma now. So people make a choice. Okay, better I do my manual labor and get my daily bread. So they don't want to collaborate actually in contact tracing. And there are other complicating factors as well, as we outlined many times. The high population mobility complicates contact tracing. And not only that, the active armed conflict, which restricts access. And the threats also coming from armed groups, some of them with names, like Codeco, like ADF, and others without names, which also affects access. So that's why we have been asking our leaders to help in ensuring some access through ceasefire and so on. And I hope the international community will take this seriously. Of course, there are the technical issues. This should be addressed, and we're doing our best, but the technical solutions alone will not give us a high rate of contact tracing. It cannot, because it's really, the environment is really complex. And on top of that, by the way, there is also aid frustration. People say, why are you pumping a lot of money now when Ebola comes? I think Helen, maybe if she's online, I told her this. While there was no money for malnutrition when we were hungry, and there was no money to treat malaria and other illnesses that are killing us. And even they say, okay, the interest in Ebola is because you don't want Ebola to come to you. Otherwise, we're not getting the support we need if it's not Ebola. So it's really complex, and that's why the mistrust comes and the even violence comes. Our centers have been attacked. I think you have heard this the last few weeks. But we're trying our best, and especially with community engagement, we believe things could improve if communities can engage and have the trust. We need to earn that. But on top of that, the other layers of complexity should also be addressed. And those who have the means to support on that, we are asking again to support. Then, finally, there was one issue I said earlier. We hope that if there are no further cases of hantavirus, WHO will consider the outbreak of hantavirus to be over by the 2nd of July. That's a piece of good news. And I say thank you to Spain, but this was a cooperation of many countries, and there are other countries also that deserve appreciation. And I would like to thank Argentina, Cabo Verde, Chile, the Netherlands, South Africa, and the United Kingdom and the United States. So without this cooperation and support, the hantavirus would not have been under control in such a short period. So as we always say, solidarity is our best immunity. And I hope this cooperation will be intensified when we fight Ebola. Then thanks to final to the members of the press who joined us today here in person and also online, and see you next time.